Welcome to the deep dive. Today, we're really digging into something quite specific, quite rare in the horse world, equine pheochromocytoma. We usually just call it PCC.
Mm,
Our goal here is to, unpack what makes this condition tick, why it's so hidden sometimes, and why it's such a challenge for vets. People might hear the symptoms and think, oh, it's just colic again.
right. But it's definitely more complex than that.
So let's start right there. What exactly is equine pheochromocytoma?
Okay, so at its core, PCC is a neuroendocrine tumor. It starts in these specific cells called chromaffin cells.
Chromaffin cells.
Yeah, they're found deep inside the adrenal medulla. That's the inner part of the adrenal gland, sitting right near the kidney. Normally, these cells have a really important job producing catecholamines.
Catecholamines, like adrenaline.
Exactly. Primarily epinephrine, which most people know as adrenaline, and norepinephrine or noradrenaline. They're key players in that rapid fight-or-flight response the body has.
Got it. So a tumor in the adrenaline factory, basically. But do they all cause problems? Are there different types?
That's a really important point. We generally talk about them being either functional or non-functional.
Okay.
The non-functional ones, well, they don't actually secrete excess hormones. They often just sit there silently. Sometimes they're only found, incidentally during a necropsy, a post-mortem exam.
Ah, so they might never have caused an issue during the horse's life.
Precisely. Almost half of the reported cases fall into that category. But the functional tumors, that's where things get serious.
Right, that's the fight or flight gone haywire part you mentioned.
Exactly.
Mhm.
These tumors are actively pumping out excessive catecholamines. And this leads to all the clinical signs we see. What's tricky is that the hormone release can be sporadic, and we call them spells.
Just spells, like sudden bursts.
Yeah, sudden bursts. They can happen spontaneously, or they might be triggered by stress, exercise, even just palpating the area during an exam.
Mm.
Now, most of these tumors, about 89% or so, are unilateral, just one adrenal gland is affected. And often they're benign, nicely encapsulated.
Okay, so benign is good, but not always.
Well, about 22% are actually malignant. That means they can spread, metastasize to other parts of the body, brain, lungs, liver, spleen, lymph nodes.
That sounds much worse. And does it affect certain horses more than others?
It typically shows up in older horses.
Yeah.
The median age is somewhere between, say, 17 and 28 years old. Though, interestingly, it has been reported in a foal as young as 6 months.
Wow, that young.
Yeah, it's rare, but possible. But generally, there's no obvious preference for a specific breed or sex.
Okay, let's unpack the functional ones more. You said it's like fight or flight gone haywire.
Yeah.
What does that actually look like for the horse when there's just too much adrenaline pumping all the time?
It means the horse's body is stuck in this state of high alert. It's completely overloaded. And this affects pretty much every system.
Okay, like what? What's the first thing you might notice?
Often, it's the cardiovascular system taking a hit. You'll see tachycardia. That's a really fast heart rate. Persistently, maybe over 60, even 80 beats per minute.
Just resting.
Yeah, resting rate can be that high. And then there are arrhythmias, irregular heart rhythms. Some can be very serious, like ventricular tachycardia. Hypertension, high blood pressure can also happen, though measuring that accurately, non-invasively in a horse is tricky.
Right.
All this means the heart muscle itself, the myocardium, is working way too hard. Its contractility is increased, and over time that can cause real damage to the heart.
And I guess in the worst case?
In the worst case, yes, sudden death can happen, either from a severe arrhythmia or if the tumor actually ruptures and causes massive internal bleeding.
Wow. Okay. So the heart is in overdrive. What else? You said every system?
Pretty much.
Mm.
Metabolically, you often see hyperglycemia, high blood sugar.
Mm-hmm.
The body's breaking down stored energy, making new
Yeah.
glucose. It's all part of that stress response ramped up. Plus fat breakdown, lipolysis, and just generally an increased metabolic rate.
Okay.
Smooth muscle gets affected too. Think about the gut. You can see altered motility. That might look like colic or ileus, where the gut just stops moving, or even diarrhea.
So it could look like a digestive issue.
Absolutely. And you might see other things like piloerection, their hair standing on end. Sometimes it shows up as really heavy sweating or patchy sweating that just doesn't fit the weather or situation.
Huh. Weird sweating.
Yeah. And neurologically, horses can be anxious, excitable, restless. You might see muscle tremors or fasciculations, those little visible twitches, especially over the flanks or shoulders.
Twitching muscles.
In severe episodes, it can progress to weakness, ataxia that's incoordination, or even collapse. And one more thing, the kidneys can suffer too. All that vasoconstriction, the narrowing of blood vessels, can sometimes lead to acute kidney injury.
That's An incredible list of potential problems. But you said earlier the signs are vague. How can such dramatic effects be vague?
It sounds contradictory, doesn't it? But the problem is many of those individual signs, colic, sweating, high heart rate, anxiety, are also symptoms of many other, much more common equine diseases.
Ah, I see. So it mimics other things.
Exactly. It's a master of disguise, especially colic. That's why getting a diagnosis before the horse dies, an antemortem diagnosis, is so rare. Most are found postmortem.
Because it just looked like really bad colic.
Often, yes. A colic that's maybe really severe doesn't respond well to the usual painkillers. Perhaps because of that internal vasoconstriction or the ileus, or maybe, critically, because there's already internal bleeding from the tumor starting to rupture.
Okay.
So the history might just be lethargy, not eating, acting painful. The exam shows sweating, high heart rate, maybe rapid breathing, dilated pupils, signs that could point in many directions. You need a really high index of suspicion to even think, could this be PCC?
This really is detective work then. If the signs are all over the place and mimic common stuff, how do vets even start to suspect this, let alone confirm it? Where do you even begin?
Well, the first step is always ruling out the common culprits, right? You have this horse presenting maybe with severe colic signs. You have to consider things like a ruptured spleen, other types of tumors in the abdomen, trauma, maybe a bleeding uterine artery in a mare.
Okay, rule out the obvious first.
Right. Or maybe the signs look more like shock or kidney disease or severe gut inflammation like enteritis or colitis, or even primary heart or lung or neurological problems. The list of differentials is long.
So are there any clues in, like, routine blood work? Anything that screams PCC?
Unfortunately, no, not usually. The lab findings are often pretty nonspecific. They might just reflect that the horse is in shock, maybe from bleeding, or just shows signs of intense stress, that sympathetic stimulation.
Like what sort of signs?
You might see high lactate levels, hyperlactatemia. Hyperglycemia, that high blood sugar, is actually a fairly consistent finding in the functional cases, so that can be a bit of a flag.
Okay, high blood sugar is maybe a clue?
Maybe. You might also see a high packed cell volume if they're dehydrated, or changes in their white blood cells that we call a stress leukogram. Electrolytes might be off. Oh, and if there's been heart muscle damage from all the stress, a marker called cardiac troponin I, or CTNI, might be elevated.
Troponin, right, like in human heart attacks. Similar principle, yes. But the gold standard test you'd think of, measuring the catecholamines themselves or their breakdown products, metanephrines and norepinephrines. That's really challenging in horses.
Why is that?
Well, first, not many labs can even run these assays reliably for horses. Second, remember those intermittent spells. The hormone release isn't constant. So you might test a sample taken when the horse isn't having an episode and the levels look normal.
Timing is everything, and probably stressful to even get the sample.
Exactly. Stress itself can elevate catecholamines, so you need to collect samples with minimal stress, which is easier said than done with a sick horse. It's tough to establish reliable normal ranges too. But there is some progress. Recent studies have shown that horses with PCC can have higher levels of these metanephrines in plasma and urine compared to normal horses. So it's a developing area, but still tricky for routine diagnosis.
Okay, so blood tests are difficult. What about imaging? Can you actually see these tumors?
Imaging is often our best bet for finding it before death. Sometimes an experienced vet doing a rectal palpation might feel a mass back there, behind the lining of the abdomen, near the left kidney, or maybe just swelling if it's ruptured.
If they can reach it.
Right, depends on the horse and the vet's experience. Abdominal ultrasound is really useful too. It can definitely show if there's blood in the abdomen hemoperitoneum or bleeding behind the abdominal lining. And crucially, ultrasound can visualize the adrenal glands themselves and potentially see a mass.
That sounds promising.
It is, but it has limitations. It can be hard to consistently get a good view, especially if the right adrenal gland is sort of tucked away.
Okay, so ultrasound helps, but isn't perfect. What about fancier imaging?
For the best detail, CT scans or MRI are considered the gold standard. They give amazing images, can really pinpoint the mass, see how big it is, if it's invading nearby tissues, or if there's spread.
But I'm guessing there are downsides.
Big downsides, yeah. Cost is a major factor. And the horse needs general anesthesia, which carries its own risks, especially in a potentially unstable patient. Plus, not every equine hospital has CT or MRI.
Availability and cost, right?
Exactly. We might also take chest x-rays, thoracic radiographs, to look for any spread to the lungs if we suspect it might be malignant.
Okay. Any other tests?
We might try to measure arterial blood pressure directly, which can show hypertension. An abdominocentesis, taking a fluid sample from the belly, can confirm bleeding. And an ECG, an electrocardiogram, is really important for identifying those dangerous arrhythmias we talked about.
So putting it all together, diagnosis is tough, requires suspicion, ruling things out, and then maybe advanced imaging if possible.
That sums it up pretty well. It's a puzzle.
Okay, so let's say you do manage to diagnose it. What happens then? What are the treatment options? It sounds like a really high-stakes situation already.
It absolutely is. And honestly, treatment is extremely challenging. Successful long-term treatment for horses showing symptoms is, frankly, rare.
Why is that?
Often, like we said, the tumor isn't even found until the horse is already undergoing emergency surgery for colic or internal bleeding. And in many of those cases, the horse's condition is so severe, the prognosis so poor, that the decision is made for euthanasia right there on the operating table.
That's grim. But if you find it earlier, maybe with imaging, and the horse is relatively stable, is surgery an option?
Surgery, removing the tumor, is considered the definitive treatment if it's a localized nodular tumor. And yes, if it's benign and they can get it all out completely, it can potentially be curative.
Okay, so there's hope there. But I sense a but coming.
A big but, or rather several big challenges. First, location. The adrenal glands are tucked way deep in the abdomen, right up near major blood vessels. Getting to them surgically is difficult, invasive. Sometimes they even have to go in between the ribs.
Wow, okay, invasive.
Second, these tumors and the glands themselves are incredibly vascular. There's a very high risk of major bleeding during the surgery or even after.
Hemorrhage risk, got it.
And third, maybe the most critical challenge. Just handling the tumor during surgery can trigger a massive, uncontrolled flood of those catecholamines.
Ah, the spells you mentioned, but like a mega spell triggered by the surgery itself.
Exactly, a catecholamine crisis. This can cause life-threatening hypertension, severe arrhythmias, even complete cardiovascular collapse, either during the anesthesia or in the recovery period.
So the surgery itself is incredibly dangerous.
Extremely. It requires really careful management before, during, and after. Often involves giving drugs beforehand, like phenoxybenzamine, an alpha blocker, to try and block the effects on the blood vessels.
Alpha blocker.
And during surgery, they might use infusions of drugs like lidocaine or magnesium sulfate to try and keep the heart rhythm stable. It takes a highly specialized surgical team and really intensive care.
Has it ever been done successfully?
Historically, the outlook was considered almost hopeless. But yes, there are more recent case reports showing that successful surgical removal is possible. It can be done, but the risks remain very, very significant.
Okay. Surgery is high risk, high reward maybe. What if surgery just isn't on the table? Is there any medical treatment?
If surgery isn't an option, then medical management is really palliative. It's about managing the symptoms, trying to control the effects of all those excess catecholamines, rather than curing the tumor itself.
Right. Making the horse more comfortable. How do you do that?
It involves medications. We might use those alpha-adrenergic blockers, like phenoxybenzamine, to try and reduce high blood pressure and improve blood flow to tissues.
Okay.
And we might use beta-adrenergic blockers, like propranolol or atenolol, to help control the fast heart rate and the arrhythmias.
Beta blockers for the heart rate. Makes sense.
BET. And this is a huge but that every vet knows. You absolutely must never use beta blockers on their own without blocking the alpha effects first.
Why not?
Because if you only block the beta effects, which can include some vasodilation, you leave the alpha effects, which cause vasoconstriction, completely unopposed. This can lead to severe, dangerous vasoconstriction and a hypertensive crisis, a massive spike in blood pressure. It can be fatal.
Wow, okay. Critical warning there. Alpha blockade first, then maybe beta blockers?
Always. Other things include general supportive care, IV fluids, pain relief with NSAIDs or opioids, managing complications like the high blood sugar or the ileus. But things like chemotherapy or radiation, they aren't really established or considered effective for PCC in horses.
Got it. So medical management is mostly about symptom control and requires careful drug selection.
That's the essence of it, yes.
So let's wrap this up then. What's the bottom line, the prognosis for a horse diagnosed with PCC? And what are the key things you want people listening to take away from this really complex deep dive?
Okay, prognosis. For a horse that's showing clear symptoms from a functional PCC, if it's left untreated or if medical management is the only path, the prognosis is generally poor to grave.
Poor to grave. Okay.
Survival time is often short, weeks, maybe months. That risk of sudden death from an arrhythmia or a major bleed is just too high.
But what about surgery, if they survive that risky procedure?
If a horse undergoes successful surgery and the tumor was benign and completely removed, then the prognosis for long-term survival and getting rid of those clinical signs can actually be fair to good, despite all the risks involved in getting there.
Fair to good. That's a significant
It
difference.
is. And of course, for those non-functional tumors found incidentally at necropsy, the prognosis during life was excellent because they weren't causing any problems.
Right. Okay. So, summing it all up, equine pheochromocytoma, it's rare, it's challenging, it's this neuroendocrine tumor messing with the fight or flight system.
Mimicking all sorts of common problems, especially colic.
Diagnosis is tough, intermittent symptoms, tricky tests, reliance often on imaging,
Definitely.
and treatment. Surgery is the main hope for a cure, but incredibly high risk. Medical management is more about controlling symptoms.
Exactly. But recent surgical advances do offer a glimmer of hope in some cases.
This whole discussion really underscores the amazing detective work that goes into veterinary medicine, doesn't it?
It really does. Piecing together subtle clues, ruling things out, it's complex.
So for everyone listening, you've now got this unique insight into a really tough equine health puzzle. And maybe it leaves you with a thought. How many other conditions, maybe subtle ones, might be out there mimicking everyday ailments? What other medical mysteries could be hiding in plain sight, just waiting for that careful observation, that persistent investigation to bring them to light?